Okay, well, good afternoon, everyone. We will go ahead and call to order the meeting for the statewide substance use response working group. And I will turn it over to Crystal Dwart to do a roll call to ensure that we have quorum today.
Okay, I'll call the roll in alphabetical order. Rob Banghart, Chelsea Cheatham, Noelle Chonet,
Present.
Stephanie Cook,
Here.
Assemblymember Edgeworth, John Firestone,
Here.
Attorney General Ford, Assemblymember Goulding, Peter Handy,
Present.
Nicole Hicks, Dr. Shayla Holmes,
Present.
Jessica Johnson,
Present.
Stacy Lance,
Present.
Giuseppe Mandel,
Present.
Kyra Morgan,
I'm here.
Senator Dina Neal, Wendy Nelson,
Present.
Rosa O'Bannon, Dr. Jose Maria Partida Corona, Christine Payson,
Present.
Bud Shaw, Steve Shell,
Here.
Senator Jeff Stone. Okay, Vice Chair Shell, we have 12 members present. So we do have a quorum of members. I do want to ask our SEI folks if you can just glance through the attendees list and see if any of our members may be stuck in the attendee and not elevated to the panelist yet.
Yeah, I'm
monitoring there.
Yeah, I'm monitoring it as well, Crystal, and I do not see anyone unless they're in under a potentially a different name.
Okay, great. Well, we can continue, Vice Chair Shell, and just a note to all members that we really need you all here for this meeting. And if you do need to depart, we'll have to rearrange our agenda. So please let us know.
Yeah, thank you so much, Crystal. Yeah, and as Crystal was just saying, if a member must depart a meeting prior to adjournment for any reason, the member shall formally announce their departure for the record to ensure accurate minutes and to allow the chair to confirm that a quorum remains in accordance with Nevada's open meeting law. And I know SCI will also be putting that in the chat. So that was just a friendly reminder to everyone. So thankfully we have quorum and we can proceed. The next item on our agenda is for information only. This is public comment. I will just make a brief statement and then we will open it up to anyone wishing to make public comment today. Public comment will be received in person at either of the locations listed above and via Zoom found on the agenda. Public comment shall be limited to 3 minutes per person. No action may be taken upon a matter raised under this item of the agenda until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241.021. Written comments can also be emailed to cdwart@socialent.com. These comments and questions will be noted in a separate document and posted with meeting materials. And then just as another reminder, members of the public joining by phone are not able to view information shared in the chat. So please do not use the chat for items other than technical support as this becomes part of the public record. And please exercise caution with links which may appear in any meeting chat as they could be malicious. So on that note, we will open it up to anyone wishing to make public comment today.
Vice Chair Shell, I do see Jamie Ross has her hand raised. Has their hand raised?
Yes. Yes, Jamie, hello. Jamie Ross, hello.
Hello, can you hear me?
Yes, we can.
Wonderful, thank you. My name is Jamie Ross for the record, ROSS, and I am the CEO of the PACT Coalition working towards substance misuse prevention in Clark County, Nevada. And I wanted to commend this group on the thoughtful prevention activities and recommendations that were put forward in this. And I just wanted to say thank you, and you have our full support.
Thank you so much, Jamie. Do we have anyone else wishing to make public comment today? Okay, hearing none, that will conclude item number 2. We will move on to item number 3. This is for possible action. This is a review and approval of our minutes from the April 8th, 2026 SURG meeting. And just as a friendly reminder to our members, in order to maintain the public record, please state your name and the specific motion you are making. So hopefully all of our members have had a chance to peruse the minutes from the April meeting. And if so, we can entertain a motion to approve. Is there anyone inclined?
This is Wendy. Yeah, this is Wendy Nelson. I approve. I motion to approve the April minutes for the SURG
Thank
meeting.
you so much, Wendy. Do we have a second?
Second.
Thank you, Noel.
Chair,
Yes.
no, I just wanted to make sure you could hear us down here.
Oh, I can hear you. Yes, thank you. So on that note, since we have a motion and a second, is there any discussion regarding the motion? All those in favor, please say aye.
Aye.
Any opposed? Motion carries unanimously. Thank you all. Moving on to item number 4. This is for information only. This is our SURG member appointment and subcommittee assignment. So I will turn it over to Dr. Terry Kearns. Hello, Dr. Kearns.
Hi, thank you, Chair. I just wanted to let everyone know that our new member is John Firestone. He's the Executive Director of the Life Change Center, and he has joined the SURG in the role of the one person who provides services relating to the treatment of substance use disorder. I would highlight that Dave Briggs was previously in that position, but he resigned due to some time constraints and conflicts. So, John, I would open it to you if you'd like to just say a few words and introduce yourself.
Sure, this is John Firestone, and I want to thank you all first for having me on your committee. I'm really proud to serve with you. That's great. So my lane is substance use disorder treatment. Specifically, I work with the Life Change Center. We help people that are struggling with heroin and fentanyl use and all classes of opioids. I'm also the president of the Nevada Opioid Treatment Association. And again, I'm just super glad to be here and be a part of this committee.
Thank you, John. Chair, that's it. That's all the new member that we wanted to introduce today.
Okay, thank you very much, Dr. Kearns.
Sorry, Vice Chair Shell, this is Crystal Duarte for the record. I would note that Senator Neal and Dr. Jose Maria Partida Corona have joined our meeting.
Oh, great. Thank you so much.
Yes, so we should have 14 members now. If any other members have joined and you missed the roll call, please let us know.
Okay, so that will conclude item number 4 on our agenda. Thank you again, Dr. Kearns, and welcome aboard, John. We're very glad to have you. Moving on to item number 5, this is for information and discussion. This is an update on opioid litigation, settlement funds, and distribution. And we have Mark Kruger with us today from the Office of the Attorney General. So I will turn it over to Mark. Hello, Mark.
Actually, Vice Chair Shell, I don't see Mark on our call yet. He may join later. We will try to get a message out to him. So if at your discretion, if you want to move to a different agenda item, we could return to that, or
Okay.
We could pause.
Yeah, thank you, Crystal. We'll pause on item number 5 and then come back to that later when Mark has joined us. So we will now move on to item number 6, which is for information discussion. This is a presentation of our subcommittee recommendations and rankings. So we will have each of the subcommittee chairs present on their respective recommendations and rankings. And I wanted to note that the chairs may have some of their subcommittee members provide the overview of some of these recommendations as well at their discretion. So I will now turn it over to Jessica Johnson, who is the chair of the Prevention and Harm Reduction Subcommittee. Hello, Jessica.
Hi, everyone. Jessica Johnson for the record. Just confirming, did the SEI team want to review the editing structure before I hop in?
Yes, we can do that. One moment, I just want to make a note that our member Bud Shaw has arrived. So I think someone might need to go get him from downstairs. So between the April meeting of the SURG and the meeting we're at now, subcommittees met and were able to revise based on feedback and discussion. And so you'll see those edits in a full handout as well as on the slide, marked in red and underlined text. So those represent changes between the last meeting and where we are at today.
Wonderful. Thank you, Crystal. Jessica Johnson for the record. I'm really honored as the Prevention Subcommittee Chair to present these recommendations on behalf of my subcommittee. We undertook the feedback received at the last meeting and other updates across the state and are here to present these recommendations for you. So in ranked order by the subcommittee at this time. So our first recommendation is to support a bill draft request in the 2027 legislative session that would double the annual state investment in primary prevention to protect prevention infrastructure via a general fund dollar line item committed to the Bureau of Behavioral Health, Wellness, and Prevention's prevention programming for people aged 0 to 24. Money should be directed to local lead agencies that prioritize evidence-based programming. This was highlighted at our last meeting, so and as a recommendation carried forward, as you can see here, from previous reports into this particular committee. Edits made at our last meeting include the red language you see here. Feedback that committees have received in the past is identifying a specific champion for bill draft requests would be helpful in carrying forward these recommendations. Our committee has not yet identified an entity or an individual, so that would be kind of a follow-up action item from this particular report. Vice Chair Shell, do you want me to take feedback one by one or present all three and then open for questions? Do you have a preference?
I don't have a preference, Jessica. Whatever's good for you. Thank you.
All right. Thank you. I'll present the three recommendations and then open if that's all right for folks. So we'll move to the next slide, which is our second recommendation. This would create a bill draft request to set aside funding for youth vaping prevention to be distributed using a local lead agencies model to reach $2 per capita, a recommended funding goal from the Nevada Tobacco Control and Smoke-Free Coalition and subject matter experts. That asterisk here indicates, given that vaping is a delivery method for cannabis, nicotine, and other substances like fentanyl, multiple funding sources should be considered, including the cannabis wholesale tax, tobacco or vaping settlement, tobacco tax dollars, the Fund for Resilient Nevada, or other appropriate sources as related to substance use. This recommendation underwent probably the largest amount of editing since it was previously presented to the larger SURG. Data were presented at an interim health committee that indicated really a need for additional support for youth vaping prevention, really to address the delivery mechanism for multiple substances and continue to support prevention across the state. There's quite a bit of update to our justification and background in the provided document that helps support this particular change in our recommendation. So happy to discuss or answer questions. Our next recommendation is our third ranked recommendation. This is to request guidance from the Nevada Board of Pharmacy to be posted to their website and communicated to pharmacists to clarify regulations pertinent to the distribution of naloxone in hospitals to permit low barrier naloxone distribution from emergency departments and permit emergency departments to adopt a naloxone specific standard operating procedure for community-based naloxone distribution, separate from and exempt from the regulatory framework surrounding hospital formulary medications used in patient care. I want to note from our presentation in April that there is a suggested or recommended language from the subcommittee as a sample post included in the associated research and links that would be provided to the Nevada Board of Pharmacy should this recommendation move forward. I think those are the three that my committee has ready today. I would be happy to take any questions from the group. Thank you.
Thank you so much, Jessica. Does anyone have any questions or comments for Jessica regarding the three recommendations from her subcommittee?
Chair Shell, this is Terry Kearns. I had a question.
Yes, Dr. Kearns.
Yeah, for your first recommendation or any recommendation for a bill draft request, and I'll lean on our legislators who are on the call. It was my understanding that the first go around are due July 1st. So I just wanted to highlight that. So it's really more of a comment than a question.
Thank you for that, Dr. Kearns. Do we have anyone who is able to respond to Dr. Kearns' question?
So this is Senator Neal. The bill drafts, I believe we have it's an August deadline. So if they're looking for a person to carry it, they would need to find them now to put in their list for August, because that's the first deadline, and then the second deadline is in December.
Thank you, Senator Neal. And Jessica, I wanted to ask you as well, do you already have someone in mind who's already committed to possibly carrying this forward as a bill draft request?
Jessica Johnson, for the record, thank you for that question. No, the committee, we just recently got Senator Neal, who joined our committee for the first time at our last meeting. Very excited to have her leadership and expertise as part of the prevention subcommittee. But no, we have not identified a group or an individual to carry these. So would welcome any suggestions or groups who might be attending here that would be interested in supporting these.
Any other discussion regarding Jessica Johnson's recommendations here from her subcommittee?
Thank you, not mine. Gratitude to my
Sorry.
subcommittee. No, it's okay.
From your subcommittee. I see Senator Neal with her hand raised.
So thank you for the acknowledgement, this Senator Neal, for the record. I just wanted to mention that on one of the recommendations, I think it's the $2 increase, they're presenting at our July 8th interim revenue. It is not determined whether or not the committee will take that on as an interim bill, but it is being presented so that the interim revenue committee can consider that measure on the July 8th meeting for interim revenue. But it has to be presented to the whole committee. But they are presenting, Jennifer Atlas and that coalition asked to come and present, and they were scheduled just to give information.
Thank you for that update. That's very helpful to know.
Okay, do we have any other discussion regarding these three recommendations? Okay, hearing none, we will move on to the recommendations from the Treatment and Recovery Subcommittee that I chair, and I'm going to be calling on my colleague, Dr. Pardita Corona, to review some of these recommendations. So starting with the first one on our list, and I would like to start out by saying that we had many, many great recommendations for our subcommittee, some of which We had so many great recommendations that we weren't able to get to all of them, that we're going to be continuing the research and the consideration of those in for this next report cycle for 2027. But just wanted to share that we did have lots of great recommendations that came forward, starting with number one from Dr. Perdita Corona. So I will turn it over to him to share this recommendation.
Hello. Okay. Can everyone hear me?
Yes.
I'm forced to use my cell phone as my mic, unfortunately. Well, this one was basically the elimination of prior authorizations needed for starting medication-assisted therapy with buprenorphine products of all types for opioid use disorder. This would apply to all payers, including Medicaid, MCOs, managed care organizations. I think this one's pretty straightforward. The goal in mind here is that since we have a very narrow window of opportunity when a patient arrives to our point of care and is willing to initiate treatment, it behooves us not to have to jump through the hoops of a prior authorization to initiate therapy. That's basically the reasoning behind this.
Great. Thank you so much, Dr. Perdita Corona. And I think we'll do like Jessica Johnson did with her subcommittee report and hold until we get through all of our recommendations for any comments from our members. This next recommendation, Dr. Perdita Corona, if you'd like to also take this one.
Sure. This one was to recommend to the Nevada Department of Human Services that they incentivize the implementation of cohesive addiction consult services. Hospitals would receive department funds to hire peer recovery specialists and or community health workers if they meet the following specific criteria: adoption of a delineation of privileges for addiction medicine as a medical specialty, as well as established protocols for the inclusion of mid-level providers and peer recovery navigators / community health workers. I think we forgot to add the community health workers there.
Yeah, thank you for that, Dr. Perdita Corona. And I wanted to mention too that when we move on to our next agenda item, we are also going to be bringing up to add the word certified before peer recovery specialists and or community health workers. So just wanted to make that note, but we'll be proposing that for action in the next agenda item. So moving on to recommendation number 3, Dr. Perdita Corona.
Yeah, this is a recommendation that insurers and payers not impose dosage limitations for buprenorphine when used for medications for opioid use disorder.
Thank you, Dr. Perdita Corona. And then moving on to recommendation number 4, we have a total of 5. So number 4 was submitted by Chelsea Cheatham and is being co-sponsored by Stephanie Cook. This is a retrospective assessment and prospective study would be conducted to assess the outcomes of all patients following discharge from certified withdrawal management facilities within 5 years of discharge, including trends in the patterns of step down and use of MOUD to examine potential contributors to overdose and develop best practices for continued care after treatment. This is something that our subcommittee found that other states have been doing, and we feel that this is very necessary to be able to help us, plan for the future and also see what the outcomes are of our existing programs. Moving on to number 5. This was also submitted by Chelsea Cheatham and is being co-sponsored by Giuseppe Mandel. Was co-sponsored by Giuseppe Mandel, and following changes at our last subcommittee meeting in March of this year, the lead on this recommendation was changed to me, Steve Shell. This is to recommend that state funding be increased for contingency management to be used to support people in recovery through rewards for reaching their recovery goals. So that completes our 5 ranked recommendations, and our subcommittee will certainly take any questions or comments from any of our members. Great. I see Jessica Johnson with her hand raised. Hello, Jessica.
Hi, Jessica Johnson for the record. I had a question regarding your first 2 recommendations, maybe 1 and 3. I'm curious, and this is like a gap in my knowledge, if things like the medication prior authorization, are those managed at the state level and so therefore could be within the power and control of like state Medicaid to change, or are those federally managed medications?
As far as I understand it, it's at the insurance level. So each insurance company can put up prior authorization requirements. So I don't think it's at the state level as much as it is at the insurance level. But I think most of them take their lead from Medicaid.
Thank you.
No problem.
Chair Shell, we have a comment from Bud Shaw related to that.
Thank you, Dr. Kearns. Yes, I'll turn it over to Bud. Hello, Bud.
Good afternoon, Bud Shaw for the record. Just a quick comment on that. Yeah, the state can absolutely, especially through Medicaid and the MCOs, provide direction in terms of what they want the MCOs as well as Medicaid to honor, and they can certainly influence that a lot. I believe that they could even go so far as actually directing certain things within the particularly again within the Medicaid MCOs. I do have another comment or question related to number 2 recommendation when you're ready for that.
We do have a comment in Carson. Oh, sorry, Vice Chair Shell. There was a comment in Carson, so I don't know if we want to take that if it's related to item number 1, Ms. Shonay.
Yes, Ms. Shonay, is your question regarding number 1?
No, regarding number 2, thank you.
Okay, we'll proceed with Bud Shaw and then come back to Ms. Shonay, if that's okay.
All right.
So, Bud, if you want to continue.
Thank you. Yeah, just a quick question related to the peer recovery specialist. Have you given any thought to the barrier of background checks for our certified PRSs and how to mitigate that in hiring decisions, particularly within the healthcare environment?
Yeah, great question, Bud. I appreciate you bringing that up. Yes, our subcommittee has discussed that. It's our understanding that currently the state is reviewing those those requirements for the background checks. And so we had made a recommendation a year or 2 ago, at least I believe it was 2 years ago, that the state consider dropping the requirement for the felony to 3 years from the current 5 years in order to, remove some of those barriers. So I do know the state is currently working on that, but that's as far as I know at the moment.
Okay, thank you.
Thank you. And then we'll go now to Ms. Shonay. I know she had a question regarding number 2.
Yes, thank you. Well, Shanae, my question or comment more, something that I'm practicing being more cognizant of is community health workers. In our tribal communities are called community health representatives, and it is not necessarily, there's not that reciprocity built into where they automatically are recognized one-to-one necessarily. So, I would pose or share out that as we look at including community health workers in many of our conversations, that we be mindful of maybe a community health representative. We do have a large tribal population in Nevada, and I think it's really important that we're inclusive of them as well when we're looking at these recommendations.
Yeah, thank you for bringing that up, Ms. Shonay. I just wanted to clarify, and we can certainly take this up for consideration in our next agenda item, but I just wanted to clarify, are you saying that it should say community health workers / representatives?
That would be my recommendation, correct?
Okay, thank you. Do we have any other questions or comments regarding these 5 recommendations?
This is Stephanie Cook, and I just have a comment on that. I think, and I is the certified, the community health worker that's certified, is that the title, community health worker? Because I think the intent here is that they're those certified people, folks. So
There
I
is a
think
certification for community health workers, if that's what your
right.
question.
And I think that's the intention here was it's referring to the actual certified community health worker. And I think that's the official certification name.
Is there a certification for representatives?
That is my understanding. I could, this is the Welsh name, we could get more clarification. My understanding from some recent work we've been doing with some partners is that they have certified community health representatives, but they do not, that training does not, is not recognized by this community health worker certification board necessarily. So it doesn't, while their roles are similar, the tribal position is a certified community health representative. And again, I am, would need to get more information to ensure that I am speaking correctly about the certification, but that is my recollection.
Thank you, Ms. Shonay. Oh, yes, Stephanie. Oh, was someone wishing to make a comment? Okay, I was just going to say that we can certainly take that into consideration in our next agenda item, where we'll actually be entertaining motions on all of these recommendations. So if there aren't any other questions or comments regarding these recommendations, we will move on to the response subcommittee that is chaired by Dr. Terry Kearns. So I will turn it over to Dr. Kearns.
Thank you, Chair. On the response subcommittee, our first recommendation, number one, is recommend that mitragynine 7-hydroxymitragynine and mitragynine pseudoindosol, including any of those isomers, esters, ethers, salts, or salt of an isomer, any synthetic, semi-synthetic, or chemically modified derivatives, and any compound containing mitragynine 7-hydroxymitragynine or mitragynine pseudoindoxil as an active pharmacological ingredient, regardless of whether the substance is naturally derived, synthetically produced, or manufactured through chemical modification, be added to the Schedule I of NAC 453.510. At the last SURG meeting, there was a recommendation for 3 of our recommendations to add both a language on scheduling as a as a category 1, or as restricting the sale to those that are under 21 years of age and under. And we discussed this in our subcommittee meeting, and as as previously noted in our last SURG meeting, the Board of Pharmacy has moved forward in their process with putting Kratom, which is what these all are, on a Schedule I. So they actually met on 4/16 of 2026. And we let them know that this was a draft recommendation, but I know that they have started their process. So because of that and the data on the dangerous effects of Kratom products, the response subcommittee decided not to add restricting the sale to those 21 years of age or under, and just leave it as having it as a Schedule I. Moving on to response subcommittee recommendation number 2, is to prohibit the sale of Amanita muscaria and its psychoactive constituents, including muscanol, ivositinic acid, and any isomers, esters, ethers, salts, or salt of an isomer, therefore, any synthetic, semi-synthetic, or chemically modified derivatives of muscanol or ivositinic acid, and any compound that produces hallucinogenic, dissociative, or neuroactive effects substantially similar to those substances to individuals under 21 years of age, aligning with existing cannabis regulations, and mandate that all products containing such psychoactive constituents have standardized labeling, including clear warnings about potential health risk and age restrictions. And again, this was one of the recommendations where the recommendation was to add the Schedule I language or restrict sales to those under 21. And the subcommittee felt that at this point, there's not enough research or data on Amanita muscaria and its dangerous effects. So because of this, at this time, the response subcommittee did not feel comfortable adding the recommendation with the language of putting it on a Schedule I. So just maintaining the restricting the sale of this to individuals under the 21 and under. Our next recommendation, I'm sorry, let me just go on to say on recommendation 2 is restricting the sale locations, about limiting the sale of these substances to licensed establishments that can verify the age of purchasers and prohibit the sale near schools and other youth-centered facilities, and then having enhanced enforcement mechanism which provide regulatory agencies with authority and resources to monitor compliance, conduct inspections, and enforce penalties for violations. We'll move on to recommendation number 3, which is to work with the prevention coalitions to make available mechanisms for safe disposal of opioid prescriptions, such as Datira bags, and to provide education to community members, groups such as youth and senior groups. And the prevention coalitions will also provide a 1-page document with information about opiate overdoses, disposal, and available addiction assistance to be provided with opioid prescriptions. The Board of Pharmacy will provide education via their website and work with the Nevada Opioid Center of Excellence for a continued education course. There were no changes recommended, and no changes were made to this recommendation. Our next recommendation is recommendation number 4. Recommend state agencies under the legislative, judicial, and executive branches involved with, as you can see in red, adult was added, deflection and diversion programs, have a comprehensive definition of recidivism and desistance, and standardized policies related to measuring and reporting recidivism. Additionally, require that all publicly funded or publicly administered reentry programs define success using clear behavior-based outcomes, and that programs articulate what meaningful behavior change looks like for participants using tools for measuring engagement, goal attainment, and behavioral milestones. At our last SURG meeting, it was brought to our attention by SURG member Morgan that there is a definition of recidivism that does exist for youths within our state. So therefore, the response subcommittee did add adult in our recommendation as reflected in that change on the screen and that I just read to you. And then our last recommendation is the ranked response subcommittee recommendation number 5, prohibit the sale of phenobut, including any isomers, esters, ethers, salts, or salt of an isomer of phenobut, any synthetic, semi-synthetic, or structurally modified derivative, and any compound that acts as a GABA B receptor antagonist or functional equivalent with similar depressant or psychoactive effects to individuals under 21 years of age, aligning with existing cannabis regulation, and mandate that all products containing phenobut or its derivatives have standardized labeling, including clear warnings about potential health risk and age restrictions. And again, restrict the sale locations, limit the sale of these substances to licensed establishments that can verify the age of purchasers and prohibit sales near schools and other youth-centered facilities. And then the enhanced enforcement mechanism to provide regulatory agencies with authority and resources to monitor compliance, conduct inspections, and enforce penalties for violations. And as again, as the other two related to this, there was a recommendation to add Schedule I or restrict sales to those 21 and under. And again, with phenobut, as with the Amanita muscaria, there is not as much research or data on the dangerous effects. And because of this, at this time, the response subcommittee did not feel comfortable adding the Schedule I language, but just continuing with the restriction of sales to those 21 and under. At this point, I would offer any comments or questions.
I see Dr. Pardita Corona with his hand raised.
So with the first recommendation, I agree that kratom is a big risk in our community and a big danger in our community. However, I'm not sure whether scheduling something Schedule 1 is really going to remove its use in our community. One of the things that I was contemplating is if before we implement this, we include some language for some sort of study to actually look to see whether this change actually reduces the amount of deaths associated with kratom use. Does that make sense? Because what we're really after here is the reduction of its use in our community. Whether it be through making it Schedule 1 or making it reduced access. So what we really want to find out is if we make this Schedule 1 and it goes underground, does it really limit the damage that kratom does in our community?
That does make sense. I would open it up to Shayla Holmes, as this was her recommendation, to see if she has any comment.
I do. Thank you so much for both of those and the opportunity. Shayla Holmes for the record. We know that substance misuse is not solved by regulation. But the issue with kratom right now is that it's publicly available, and the way that it is publicly available, individuals are unaware that it is dangerous because it could be purchased at pretty much any location. And the reason why, and we've talked about this a lot and had a lot of different presentations about Schedule 1 versus sale restriction versus other things that could be done, as you saw through some of the other recommendations. And kratom specifically, we went straight for Schedule 1 due to the amount of deaths happening in our state related to kratom. So it really rose to the top in regards to needing to be addressed as a public safety measure to Schedule 1. Individuals that are going to utilize underground substances, they're going to find them and they're going to utilize them. Scheduling this substance will not address that, but it will potentially save lives for individuals whom are utilizing it and purchasing it over the counter, who are entirely unaware of its potential effects.
I'm just wondering if by making it restricted to 21 and older and say taxing it, if we can do with it what we did with cigarette use. If you think about it, cigarette use went down in younger populations, I think partly because of how well informed the society as a whole is now of the dangers associated with smoking. And though I believe me, I am in full agreement of the dangers of kratom, but I think where we will succeed in seeing the reduction of the use of kratom is when we educate the population as to why it's dangerous. And that's why I wonder if that different tact of making it 21 and older and taxing it heavily may be a better route, if we can use those funds to educate about the risks of kratom.
Shayla Holmes for the record. Well, I really respect the thought process. I would urge us to consider what we did with tobacco in regards to that tax rate goes right back into the education. And tobacco, while it does kill folks over time, kratom is killing people immediately via overdose. And as a public health and safety measure, I think that the amount of time it took to educate the community as a whole on tobacco, and if we look at what's still happening with tobacco and now vaping and the alternatives of that through it being just restricted, I have grave concerns as far as how many people will continue to die if we just restrict it to age. Although I wholeheartedly can see the thought process there. I think we've got a lot of lessons to learn in regards to how we handle substance use. You know, we haven't figured out that magic bullet yet, but the coroner's office and a lot of the death data regarding kratom is what landed us on the Schedule 1 component. But I totally see your perspective.
And actually, you bring up a very legitimate point, and that we're working with a very much more narrow window of opportunity there, because these deaths do happen at a much younger age. Okay. And at the very least, maybe see whether we actually do manage to reduce deaths by this change, because I think that would be worthwhile information.
Okay, I see Jessica Johnson with her hand raised.
Hi, Jessica Johnson for the record. Thank you to the response subcommittee for your thoughtful preparation of these recommendations. I have 3 questions, so I'll ask them in order. I was wondering, since we're on recommendation 1, has a Schedule 1 been adopted by any of our neighboring states in Nevada?
Shayla Holmes for the record. I would have to go back to the research, but yes, there are several states that have scheduled 1. I don't know the appropriate way to say that. Scheduled it as a number 1 classification. And then there are several other states in the process.
Okay, thank you very much. My second question was regarding recommendation number 3.
Hey, Jessica, can we wait? We have some more comment on 1.
Oh, sorry.
If
Yes,
that's okay.
absolutely. That summarizes my comment on recommendation 1.
First, I wanted to comment, Terry Kearns, for the record, that I was contacted by lobbyists for the kratom industry. And from what my conversation with them went is the industry is actually in favor of scheduling everything except for natural kratom. So then the natural product, but all of the other synthetics and semi-synthetics, I believe they are going to be in favor of scheduling those. And then Bud Shaw had a comment.
Hi, good afternoon. Bud Shaw for the record. I reached out during our discussion to our medical director for the emergency department at UMC. And we were pretty much the epicenter for EDC and all major happenings here in the area. And with your permission, Chair, I'd like to read into the record his comment related to kratom and the Schedule 1 classification.
Yes, please, Bud. Thank you.
Thank you. Schedule 1 classification of whole leaf kratom is not supported by clinical evidence and would likely produce net harm by impeding research and potentially increasing use of more dangerous opioids. However, concentrated 7-OH products warrant controlled substance status. Given their higher abuse liability, the priority should be product standardization, surveillance, and clinical trials to establish whether kratom constituents have legitimate medical applications for pain or opioid use disorder. And he recommended that we do some additional things, but just a comment from one of our doctors that are on the front edge of this. Thank you.
Thank you, Bud. Jessica, did you want to proceed with the rest of your questions?
Please, thank you. Regarding recommendation number 3, I was wondering, I was thrilled to see a distribution through the prevention coalitions. I think that will ensure diffusion and reach throughout the state. I was wondering if there are funds associated with this recommendation, or just a collaboration, or is it aligned with an action that prevention coalitions are already undertaking statewide?
In our conversations, I think the funding, which is in the supporting documents, was to request funding from the Fund for Resilient Nevada.
Thank you for the clarification. My other comments are recommendations 2 and 5 together, so I just wanted to pause, Vice Chair Shell, if other folks had comments related to 3.
There's
Were there
a
any
question or comment here in Vegas for number 2.
Yeah, Giuseppe Mandel for the record. Just to bring up as far as the 7OH and the Kratom again, I have been getting calls, just one of last week, from a major hospital and director of case management asking that they are seeing a big uptake in Kratom sales and they're being purchased at Walmart, and they want to know who they could report it to. And with that being said, also working in the treatment centers, it causes a potential problem for us as well, because with the abuse of 7OH or Kratom, we cannot get authorization for treatment, being that it is not a Schedule 1 narcotic. So therefore, insurance will not authorize any type of treatment, and the withdrawals are brutal on it. There is death takes on it. And Dr. Petita Corona, I know that you mentioned education and stuff. Just I do encourage, like what Bud said, it's more investigation, because if you do look at it out there, there is a lot of information regarding it that says it's beneficial. Say there's large veterans groups that say it's a beneficial alternative to opiates. Large number of information out there saying that it's got a lot of health benefits, which none are actually proven. And this is causing people who would not normally use an opiate to use substances like Kratom. And as far as the black market, I can tell you from a lived experience, it does not have the value on the streets for the black market. So if it was scheduled to that, you're not going to have a huge uptake of black market sales for Kratom on the streets. It would then go to where the market value is for fentanyl or heroin as far as opiates, and it would phase its way out just like kind of Spice did.
Dr. Pardee, do you have a
comment? Sorry, Bud Shaw again for the record. Just real quick comment. I'm wondering if there would be any latitude to place the drug on Schedule 1, make it a Schedule 1, but provide some sort of legislative relief or caveat for being able to use it under studies or to further study the drug.
Dr. Kearns or Dr. Holmes, do you have a response to that?
This is Shayla Holmes for the record. I'm not sure of what the clinical trial requirements are and if things under Schedule 1 can be still included in clinical trials. I believe that there are currently scheduled narcotics in clinical trials for certain things. So I don't think scheduling that in Nevada will limit its ability to go through appropriately vetted and approved studies. That's my general understanding, and I'd have to do more research on that.
Okay, Dr. Pardee Corona.
Well, now between Giuseppe and Dr. Holmes' mention of the rapidity of people dying from 7OH, I have to agree with them. I think it should be Scheduled 1. You convinced me.
Thank you. I would add Terry Kearns for the record. I was at a drug endangered children conference, and a nurse practitioner that worked with neonatal abstinence syndrome in Indiana or Iowa, somewhere in the Midwest, said that they had a baby that was going through some of the worst withdrawals that they had seen, and they couldn't figure out what it was. Mom had denied any illicit drug use and kept going further and further, and the mom was using Kratom, and she said she didn't even think of that as something. She thought of it as a supplement, not something that would harm her baby. And that story just stuck with me. It's an anecdotal story, but. Jessica, did you have other questions?
Yes, if appropriate, I was going to move on to numbers 2 and 5. So just, is that all right, Vice Chair Shell?
Yes, let me just ask Stephanie if she's still, if she's got her hand raised, Stephanie Cook, and see if her question is regarding this current discussion.
Yeah, I think it is. I just wanted to offer, as the State Opioid Treatment Authority, I work very closely with our opioid treatment programs and others in this space across the nation. And there is our friends at SAMHSA are working on very closely with the FDA on kratom and issuing good, solid guidance on treatment aspects. But I will say that Tennessee is scheduling this right now, and I think it's almost through their process. So if we need a state to maybe look at, Tennessee might be one to mimic what they're doing in scheduling this.
Thank you,
Right.
Stephanie. And I would add, I know that through Board of Pharmacy, their process is not a quick process in my conversations. And correct me if I'm wrong, Dr. Holmes, it may be a 2-year process in all of the different things that they have to do to get this scheduled.
Shayla Holmes for the record. Dr. Kearns, you are correct. It's a 2-year process, and they started that process with their first public hearing, and then there will be several others on their timeline leading up to it. And there are several other states, I think Arizona, Wisconsin, there's a couple, there's about 7 or 8 that have already successfully scheduled it as well.
I see Stephanie Cook with her hand raised.
Yeah, I just need to let you know that I have to drop off at this time.
Okay, thank you so much, Stephanie. And just to note that we still do have quorum with Stephanie Cook departing. I see John Firestone with his hand raised. Is that regarding this recommendation, John?
It is. This is John Firestone for the record. I want to speak just on behalf of the opioid treatment centers, and we are seeing a lot of kratom-related problems. Certainly not in the scale that we see things like pills, heroin, or fentanyl, but it is a concern of the opioid treatment programs that not only do we would support the Schedule 1 classification, but we really need guidance for medication-assisted treatment for kratom. It doesn't fit nicely into the boxes that we have for that.
Is
Chair,
there
we
any
have
response to John? Oh, go ahead.
We have another comment down here.
Yeah, again, Bud Shaw for the record, and this will be my last one. And just to be clear, much to the comments that we just heard, Dr. Obert, our medical director in the ED, wasn't and is in favor of actually moving the, particularly the 708 to a Schedule 1, and if it needs to be the whole genre, then that'd be it. He is in favor of Schedule 1 as well.
Great. I think at this point we can move back to Jessica Johnson to.
Thank you. Jessica Johnson for the record. I had a question related to recommendation 2 and 5. I think specifically in I don't have any concerns about how they're written. I'm just reflecting on the presentations that the Prevention Subcommittee received from the Nevada Tobacco Prevention Coalition. In that, in reflecting on things like the cannabis wholesale tax and these other areas, that none of that money is earmarked specifically for prevention. So I'm wondering if the committee considered, and Dr. Partita Corona alluded to this earlier, an opportunity for taxing these psychoactive substances and appropriating that tax for the prevention, specifically for that aged 0 to 24, to help ensure education, particularly among youth, about these substances. Thank you.
Thank you
Shayla
for
Holmes for the
that
record.
comment. Go ahead, Shayla.
Sorry, Terry, I was holding out thinking you were going to go and then I just went. Shayla Holmes for the record. I don't recall us discussing taxation at all. I don't think that is a bad idea. I think any way that we can generate funds to go towards prevention, the better off we'll be. So, I mean, I'm certainly open to that recommendation for change.
Dr. Curtis, did you
I
have anything to
agree.
add to that? Okay.
I don't, just that I agree.
Okay, thank you.
Jessica Johnson for the record, thank you for entertaining that thought. I'd be happy to share any of the resources we'd received from the Nevada Tobacco Prevention Control. Apologies. I'm getting the name of the coalition wrong that presented to us. So hopefully I can update the record on that. But would be happy to share any of the presentation resources. And we received quite a few recommendations from their committee that outlined many of the variety of funding sources to help identify resources specifically for prevention. So I do think maybe thinking through if a tax were levied as part of these recommendations, then specifically who that group would be and identifying it specifically for the prevention of use of these substances seems to be a lesson learned from some of the other areas across the state. So I'd be happy to provide any resources that the prevention subcommittees received related to this, if helpful.
Thank you. That would be.
And then did that complete your questions, Jessica? Okay, thank
Sure
you.
did. Thank you so much.
Thank you. So do we have any other questions or comments for the response subcommittee's recommendations?
I do. This is Wendy Nelson.
Yes, Wendy.
Yeah, so I just wanted to put out there that one of the biggest issues, I run a prevention coalition, that we're seeing with the youth in regards to Kratom is they have single shot bottles that are marketed like energy shots and sweetened canned beverages. And then they have just different products that contain, concentrated extracts. And that's, it's kind of marketed towards, people thinking it's just like an energy drink, you know what I mean? And things like that. And as you know, with energy drinks and all that, they're combining things, I think that's where we're getting into a lot of the dangers as well. They're just, and there's really powerful drinks that are mixed with kava and that. And so, and a lot of our prevention funding streams really haven't covered Kratom, and we have talked about it, at the federal level, and they kind of warned us this was coming down, but there's a lot more in prevention that we need to do some messaging on this. So I'm excited to see where this is headed.
Great. Any other questions or comments regarding these recommendations? Okay, that will conclude item number 6. We will move on to item number 7 for possible action. This is the approval of our 2025-26 recommendations. So just to note, and as a reminder, our subcommittees met in May of this year to finalize their recommendations and rank them in order of priority within their respective subcommittees. So that's what was just presented under item number 6. We now need to take a vote on each subcommittee's slate of recommendations individually. And in doing so, any SURG member can request discussion and/or changes to any recommendation or the ranking order. And then any proposed change must be voted on by the full SURG with separate motions made for each recommendation. And then I just wanted to give all our members a friendly reminder to please state your name and make a clear and detailed motion. For example, approve as is and as ranked, or approve with revisions as ranked, or approve content with a change in ranked order. So on that note, we will start with the prevention and harm reductions recommendations. Moving to our next slide, I believe. Oh, perfect. And at this point, we would certainly open the floor to our members on any motion to the effect that I just stated, either to approve them as is and as ranked, or to make a motion to make any changes to any of the recommendations.
This is Shayla Holmes for the record. I would make a motion to approve as ranked the prevention recommendations 1 through 3.
Thank you, Dr. Holmes. Do we have a second?
This is Dr. Pardita Corona, second.
Thank you, Dr. Pardita Corona. Do we have any further discussion regarding this slate of recommendations from the Prevention and Harm Reduction Subcommittee? All those in favor, please say aye.
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 Any opposed? Motion carries unanimously. So thank you to the great work of the Prevention and Harm Reduction Subcommittee. So thank you. Okay, moving on to the treatment and recovery recommendations that we also just went over in the last agenda item. I do know that there was a recommendation to, well, we had said from our subcommittee that we wanted to add the word certified to recommendation number 2. And then I also know Ms. Shonay had some feedback regarding that as well, regarding representatives. So this would be the point where we could entertain a motion specific to this recommendation and consider that, and then go back and entertain a motion to consider the full slate of recommendations. I see Dr. Pardita Corona with his hand raised.
Yeah, I motion to make affirmation changes with representative and with certification.
And Dr. Pardita Corona, let me just clarify, are you saying, is your motion to add the word certified where it says department funds to hire certified peer recovery specialists and or community health workers?
Correct. And to add slash representatives after workers.
Okay, thank you.
Thank you.
So that is the motion we have on the table at the moment from Dr. Pardita Corona to add certified peer recovery specialist and or community health workers / representatives.
I second Robert Banghart.
Thank you, Rob. Do we have any further discussion regarding the change to this recommendation number 2? All those in favor, please say aye.
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 Any opposed? Okay, motion carries unanimously specific to recommendation number 2. So at this point, we can entertain a motion to approve the full slate of recommendations from the Treatment and Recovery Subcommittee as written, unless there is another motion to make a change to a specific recommendation.
This is Dr. Partita Corona motioning to approve the whole slate.
Thank you, Dr. Pardita Corona. Do we have a second?
Noel Renee, second.
I'm sorry, I didn't get it. We had several speaking at the same time. Do we have a second?
Noel Shanae with a second.
Thank you, Ms. Shanae. Any further discussion regarding this slate of recommendations? All those, I see Jessica Johnson with her hand raised.
Apologies, just a point of edit. Chelsea Cheatham's name is spelled incorrectly on these submission details. I was just hoping we can update that for the record. It's Chelsea with an I.
Okay, thank you so much, Jessica. Yeah, what Jessica has just pointed out is actually in the justification section for each of the recommendations, so we can certainly make that change.
Apologies, Steve.
No, thank you, Jessica. Any other discussion regarding the motion on the table? All those in I see Dr. Pardita Corona with his hand raised.
Sorry, Steve, your name's misspelled there as well.
Oh, I didn't catch that. Thank you, Dr. Pardita Corona. Yes, it should be Shell, Shell. Thank you. Any other further discussion regarding this slate of recommendations? All those in favor, please say aye.
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 Any opposed? Motion carries unanimously. So thank you as well to the Treatment and Recovery Subcommittee on these recommendations. So moving on to the Response Subcommittee recommendations. Again, we can entertain a motion to change a specific recommendation, and then also entertain a motion to approve the full slate of recommendations as is. I see Jessica Johnson with her hand raised.
Yeah, Jessica Johnson for the record. I'm curious if the committee was planning to add details related to taxation to the recommendations 5 and 2. If they wanted to go back and workshop these, I don't, is this the only opportunity to like review and approve these? Like, would that be, I'm not trying to hold up with one idea, some very well thought out and detailed recommendations. I just didn't procedurally. I wanted to just ask that question before moving these recommendations forward.
Dr. Kearns, do you want to respond to that? Or?
Yeah, thank you. I was just getting ready. Terry Kearns for the record. Jessica, do you suggest adding that under the actions that is in the supporting documentation? Keeping the recommendation as is, but adding about the taxation, taxes to go toward prevention and education, and adding who would be taxed as part of the actions?
Jessica Johnson for the record. I have the document up. I just want to thoughtfully consider your question for just one moment. Okay, Jessica Johnson for the record. I'm not an expert here, so if there are maybe policymakers or other folks on the line who could help provide some guidance here. I do think that action step would be one place. I am wondering though, in kind of the brief summary of these and the way that restrict sales locations and enhance enforcement mechanisms are pulled out specifically in the recommendation itself. If the committee or if the subcommittee would be open to adding details there in a similar fashion.
Shayla Holmes for the record. I think given the time frame and the action of today, perhaps an amendment could be made to this recommendation, and I think it's number 2, under enhanced enforcement mechanisms, to add a line that says, and create or identify taxation mechanisms for prevention purposes. And then the action item, we could get into what those specifics need to be for the report. But I think for the purpose of amending this recommendation, I think we could keep a simple line in there, just that we would also like to explore taxation options for prevention.
Jessica Johnson for the record. I think that does solidify. I agree with that. So your suggestion is under the enhanced enforcement mechanisms?
Yeah, I would go another line and make a statement regarding and explore taxation options. I think it would be best if it was separate because I don't think it's a part of the enforcement.
Okay.
Maybe it is. There we go. Yeah, explore taxation options for prevention. I think the for prevention piece might be critical as a part of the recommendation, but then within the action item, identify the technicalities that might be needed to be explored further.
Thank you for consideration. So this would be for 2 and 5, if the subcommittee and others on the SURG committee are open to that addition. Thank you, Dr. Holmes and Dr. Kearns, for the opportunity to provide thoughts here.
And okay, so I think for Vice Chair Shell's needs, I'm going to make a motion to amend recommendations 2 and 5 to add the line explore taxation options for prevention.
Thank you, Dr. Holmes. Do we have a second?
Wendy Nelson, I second that.
Thank you, Wendy. Do we have any discussion regarding this specific motion? I see Dr. Perdita Corona with his hand raised.
Yeah, the only thing that I wanted to add is if we could put options for education and prevention, simply because that opens up the possibility of using those that taxation to get to do research as to whether or not these changes are making a difference. Does that make sense? Instead of limiting it to prevention.
I think it does, but I think with the current motion, we either need to have that die via people not voting and then amend.
Yeah, good point, Dr. Holmes. Let's consider the current motion on the table, and then depending on that vote, we can come back and entertain what Dr. Pardita Corona just came up, what he just mentioned. So given the current motion on the table, all those in favor, please say aye.
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 Any opposed? Okay, so it sounds like the motion has been approved to add explore taxation options for prevention. So then on that note, do we have any other motion to be raised, either specific to any of these recommendations?
But shall make the, go ahead.
No, go ahead.
I'd make the motion that we add for education and prevention to that line.
For both number 2 and number 5, Bud?
Yes, sir.
Okay, thank you. So we have a motion on the table from Bud Shaw to amend the recently amended number 2 and number 5 recommendations to include the words education and. And so on that note, do we have a second to the motion?
Jose Partida Corona, I second.
Thank you, Dr. Pardita Corona. Do we have any further discussion regarding this specific motion? All those in favor, please say aye.
Aye.
Aye. Aye.
Any opposed? Motion
Opposed.
carries unanimously.
Sorry, Chair Shell, I just wanted to note we did have an opposition here in Carson.
Oh,
So for
thank
the
you.
record.
Okay, so the motion was approved, but not unanimously. So I will note that for the record, the motion was approved. Thank you.
Thank you. And just for the record, I wanted to note that it was Member Shernay
Okay.
who provided the opposition.
Thank you for that, Kim. Okay, so continuing on, at this point, if we don't have any other motions being made regarding specific recommendations, then we can entertain a motion for the full slate of recommendations from this subcommittee.
Bud Shaw also moved.
Thank you, Bud. Bud is motioning to approve this full slate of recommendations. Do we have a second?
Partida Corona, second.
Thank you, Dr. Pardita Corona. Any further discussion regarding this motion? I see Peter Handy with his hand raised.
Yes, thank you. As Peter Handy, I'd kind of like to raise a point of order as to recommendation number 1. I feel like it's outside of the scope of this working group's purview and statutory authority to be recommending scheduling a substance as Schedule 1 to the board, in part because the board has its own statutory authority and requirements to schedule items, but also specifically including items in particular schedules isn't an authority given to this board. While we can make recommendations to the Board of Pharmacy, it's to ensure controlled substances are appropriately prescribed in accordance with the provisions of Chapter 639, and that doesn't include Schedule 1 substances, which by their nature are prohibited from being prescribed.
Okay, thank you for bringing this up, Peter. Do any of our members wish to address that during this discussion regarding the motion on the table? Okay, hearing no further discussion, all those in favor of approving the motion, please say aye.
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 Any opposed?
Nay, for the reasons stated.
Okay, thank you, Peter. So motion is approved. So thank you again to the response subcommittee for all of your recommendations, and thank you again to all 3 subcommittees. I know this was quite a bit of work. We got through this today in a great amount of time, a great discussion. So we really appreciate all of your efforts in this. That will conclude item number 7 on our agenda. We will move on to item number 8. This is for information and discussion. This is a review of the annual report template. So I will turn it over to Crystal Dwart with SEI. Hello, Crystal.
Thank you, Vice Chair Shell. So I'm going to just walk through the annual report. It does look different from the one in January because we will now be including the recommendations that were just approved. You can see here that the report date is August 1st. That's our new time frame per AB 19. And just as I walk through and pause on the table of contents, I wanted to let everyone know there is an executive summary that could be pulled out of this report that will list the recommendations that were just approved without some of the detail. And then the rest of that detail will exist in the body of the report. Going to the overview section, that does describe the change in timeline for our reporting schedule as well as our membership that occurred in AB 19. And if you remember back in January, we had some conversation about how that was noted. It is included in here. It's not highlighted in quite the same way because this does represent a full and complete report per the legislation. So that section, you can see how we assign different areas to the various subcommittees. And that's all in the background. And then the process section describes who our chairs are and how the recommendations are developed. You'll see in here, if you look at page 8, we have blanks because we did not know how you would rank today's or revise today's recommendations. So beginning on page 8 are going to be more of the details about the recommendations. And so those would be listed here as ranked by the subcommittees, followed by the justification, background, and action steps. Some of the additional information that is submitted by members will be in appendices just to keep this section detailed, but not so long that nobody can get through it. So where you find a lot of other details are in the appendices, and I'll just have Mary pause there. You can see that the additional information for the recommendations will include the research links that have been submitted and added to over time related to each recommendation. We then, in appendices B and C, look at all of the recommendations and create some tables and charts to identify which of the target populations are being impacted by those recommendations. And that helps the subcommittees and others identify where in the coming year we might focus the development of recommendations. And same with the legislation addressed. If there are aspects of the legislation that are not being addressed, that might be an area for a recommendation in a future year. Appendix D is also a work in progress. That is going to include recommendations on the updates on the 2024 recommendations. We included this in the January report as well. And we have asked all of those reporting entities to provide us with any updates that might have occurred over the last 6 months. So that information is coming. I think we have a deadline of June 15th for those updates. And that also is information that I think is valuable to members to have for the coming year to identify where there may be areas to make additional recommendations and further those items. So we really appreciate our partners that do provide that information from the Fund for Healthy Nevada, Fund for Resilient Nevada, Department of Human Services, Nevada Health Authority, and the Governor's Office. Appendix E is information regarding SURG membership and the presentations received. We feel like this gives the public a better idea of how you formulated recommendations and the experts that you relied on to help guide that process. And then we have information regarding opioid settlement funds. As you know, we'll get to Mark's presentation after this. But we also have in there information on the Fund for Resilient Nevada dashboard to identify how those funds are being spent. And the final thing is the signature, which is signed by the Attorney General. I'm happy to take any questions about the format of this template. You will be approving the final version and its content in July. So any edits that you see we would need to make, we would like to know those now so that in July we have an easy, breezy approval of the report.
Okay, any questions or comments for Crystal? Okay, thank you so much for that overview, Crystal. Okay, that will conclude item number 8. We are now going to go back to item number 5. on the agenda, which is an update on opioid litigation, settlement funds, and distribution. This is for information and discussion. So we have Mark Kruger with us from the Office of Attorney General. I will turn it over to Mark. Hello, Mark.
Thank you, Chair. Mark Kruger, for the record, Chief Deputy Attorney General, Bureau of Consumer Protection in the Attorney General's office. I think we skipped last month, if I recall correctly. So there's been a little bit of movement in the settlement area, and most notably, Purdue has finally, the confirmation plan for the bankruptcy has finally been confirmed by the bankruptcy court. We don't anticipate getting a payment until much later, potentially September or October of this year. The bankruptcy court confirmation was half of the Purdue settlement. The other half is the settlement with the Sacklers that has been accepted. We are working on filing a consent judgment to finalize that private settlement, and they work together. The good news is that I'm getting reports that we will get at least as much money that was projected, if not potentially a little bit more, due to the sale of some of the assets from the Purdue company as it emerges into a new company from bankruptcy. So we're looking at the total recovery of about 57. Fine. Okay, $57,941,000. My apologies for that interruption. The other thing that I wanted to update everyone on is a settlement with several other companies. We call them other tier manufacturer companies. Apotex, Alvagen, Zydus, Sun, Mylan, Amneal, Hikma, Indivior, and those particular settlements roughly are about $8.9 million. We just finished filing consent judgments on them, so they're wrapping up, and I anticipate getting payments on those sometime in September as well. So with that is kind of an update of where we are, and I'll open it up to questions.
Any questions or comments for Mark? Okay, Mark, thank you so much for those great updates. We appreciate it.
Great. Thanks, everyone. We'll see you next month.
That will conclude item number 5. We will now go back to item number 9 on the agenda. This is for possible action, a review and consideration of items for our next meeting. So I will turn it over to Dr. Terry Kearns.
Thank you, Chair. Currently for our upcoming meeting, so the July meeting which is July 8th at 2 p.m., we have to approve the 2025-26 annual report, which is laid out by Ms. Duarte. And then in October of 2026, specifically October 14th at 2 p.m., we have presentations from subject matter experts on the crisis stabilization centers and morbidity or mortality rates. Those are both pending. And then an overview of the open meeting law, which also is pending. That's currently what we have. If anyone has any other recommendations, I welcome those now, or please email me.
Any questions or comments for Dr. Kearns? Okay, thank you so much, Dr. Kearns. That will conclude item number 9. We will now move on to item number 10 on the agenda. This is public comment for information only. I will just make a brief statement and then we will open it up to public comment. Public comment will be received in person at either of the locations listed above and via Zoom. Public comment shall be limited to 3 minutes per person. No action may be taken upon a matter raised under this item of the agenda until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241.021. Written comments can also be emailed to cduarte@socialent.com. These comments and questions will be noted in a separate document and posted with meeting materials. And just as a friendly reminder, members of the public joining by phone are not able to view information shared in the chat. So please do not use the chat for items other than technical support, as this becomes part of the public record. And also exercise caution with links which may appear in any meeting chat, as they could be malicious. So on that note, do we have anyone here today wishing to make public comment? Do we have anyone in the north or anyone in the south in person?
We do have public comment in the north, but I'm not sure if, I think in order we go south first.
Oh, thank you, Kim.
We do
So
have-
starting with the south, do we have anyone in the south wishing to make public comment?
We do.
Giuseppe Mandel, Vocal Services, for the record.
Yes, Giuseppe.
I wanted to just thank you all for your commitment to the work and to the cause. Really appreciate you all being here in your busy days. And especially, it is nice to see somebody from the tribal community attending as well. Much welcomed, and appreciate you joining.
Thank you, Giuseppe. Anyone else in Southern Nevada?
No,
Okay, moving
that's
to,
it.
okay, thank you, Dr. Kearns. Moving to Northern Nevada, do we have anyone there wishing to make public comment?
Yes, Nilesh, and I just wanted to thank everybody for all their work on these recommendations. I know just kind of completing my first year almost on this committee, I really see the passion and the depth of research that goes into this, both with SEI, the subcommittee members, chair. So really appreciate you all. It's amazing document that gets put together by this group. So thank you.
Thank you, Ms. Shanae. Anyone else in Northern Nevada wishing to make public comment? Okay, do we have anyone on the phone wishing to make public comment? Okay, hearing none, that will conclude item number 10 for public comment. We'll move on to item number 11, which is adjournment. We'll look forward to seeing everyone at our next full SURG meeting on July 8th. So in the meantime, please take care, and thank you all for being here today. Our meeting is officially adjourned. Thank you all.
Thank you.
Thank you.
Bye-bye.